So my talk will be on ESD in the stomach, mainly focusing on the diagnosis and indications and decision-making for treatment. And I'll go in to the ESD procedure itself, although not fully into detail. Maybe we can have that in a later presentation, hopefully. Well, so first things first, let's start with how to find lesions and how to make a treatment plan. So if we talk about gastric cancer, probably this is a summary of things that a lot of you already know. Gastric cancer, especially the intestinal type, has precursor lesions that we are well aware of, and we can find them during endoscopic procedures. And if we do, we can make our decide on proper management in follow-up, or when we find lesions on endoscopic treatment. Because as you know, gastric cancer is a huge problem. If gastric cancer is diagnosed, it is the fourth most common cancer worldwide, and the second leading cause of mortality worldwide. So usually when we diagnose gastric cancer, this is kind of a death sentence for a lot of patients, despite all what we think we can do. Maybe we think the problem is less relevant in the West. It's for sure the incidence is higher in the East, but also in Europe, especially in Portugal, there is high incidence of gastric cancer. This is what we see in the Netherlands. The incidence has declined over the years, but now from 2016 on, it's more or less stable, around 1,500 cases per year. And if we look at how these patients do, despite all therapy, you can see in this graph that the 1-year survival is less than 50%. And that was the case in 1989, but it's still the case in 2012. And I can already tell you that it's still the case in 2020. So a lot of these people, by the time we diagnose the gastric cancer, they are beyond cure already. So if we want to turn the tide, and we can, we should be able to detect the early lesions, because that's the lesions that we can cure. And most advanced lesions, we have a lot of therapy, we have surgery, we have chemotherapy, but the percentage of cure is very small. So I showed you this slide already. Gastric cancer has precursor lesions. So we should try to find these lesions, and these lesions are very well amenable for endoscopic treatment. So how can we find these lesions? First of all, the prevalence, if we look at atrophic gastritis, it comes with age, as we probably all know, but the intestinal metaplasia and finally dysplasia in the cascade that I just showed you also increases with older age. So it's in the older people that we will find these lesions. And this is a publication already from 2017 from our group in Rotterdam, showing the prevalence of these lesions in the Netherlands. And if you look at the risk of developing cancer, oh, sorry, I see part of this slide is still in Dutch. From diagnosis, when the first 1 year after diagnosis, for instance, high-grade dysplasia, there's already cancer in 25% of patients. And that is less for atrophic gastritis only, and also for low-grade or intestinal metaplasia only. And if we do follow-up, of course, the risk, the annual risk is not very high, but there is still an increased risk compared to the normal population. Sorry. So, but still, it seems that these lesions are hard to find, and actually, a lot of these lesions are also missed. So we have this opportunity to find an early lesion, and in a lot of cases it turns out we miss it. This is a review of studies that looked into that, and it turns out that we miss somewhere between 8 to 10% of lesions because these people have gastric cancer, and they all had an endoscopy where no cancer was found in a short time previous before. So why is that? Why do we miss these lesions? Of course, we know that they can be very subtle, and usually we do endoscopy for different regions, and we find them like coincidental findings. So when we do endoscopy for alarm symptoms like bleeding, etc., usually we focus at the bleeding, but we don't look around for early lesions. Also, experience is an important factor. Here in these studies, insufficient biopsies came out as an important factor, and careful looking at blind areas. And as we all know, in the stomach, there are a few blind areas that are sometimes hard to detect. In these two pictures, it's always easy when the arrow points at the lesion, but here at the lesser curvature, near the gastric angle, there is a subtle lesion, and on forward view only, you might easily miss that. And here in retroflex, of course, we see the lesion. And when I show you in this, you probably cannot imagine that this lesion is missed, but this is a typical lesion that is missed during endoscopy. And this is another important finding, that even when we do find precursor lesions, sometimes there is no follow-up, no surveillance, despite that we found a precursor lesion. So in this graph, you see displayed the number of endoscopies in these specific groups. So going all the way to the right, there were people with severe dysplasia in a biopsy, and a lot of them didn't even have a follow-up endoscopy. 40% of them only had one, and a few of them had more endoscopies because of this. Of course, this is database research. There can be a lot of issues here that we're not aware of, but it shows that even when we detect atrophic gastritis or metaplasia or even dysplasia, there's not always good follow-up as it should. One of the easy things that we can do, so how can we improve our endoscopic yield? Well, one of the things is to use bubble breaker. It's very easy, it's a Medicon. Give all patients a small cup to drink just before the endoscopy. It's only 2 cc in water, and you get rid of all the bubbles, and your view improves perfectly. And then, of course, we should always use our best endoscopes. Well, we always want to use our best endoscopes and carefully look around, but not only with white light, but also with chromoendoscopy functions on the endoscope, like narrowband imaging. In a routine endoscopy imaging report, in Europe, we're more or less trained to have at least 8 standard pictures taken from a diagnostic endoscopy without any abnormalities. In Japan, it's more around 30 pictures for a standard endoscopy, so there is a bit of a difference there, and I think we can certainly learn from that how to look carefully for subtle lesions. But it should all be perfectly clean, without any bubbles. Because if you see pictures with bubbles, there could something like a subtle lesion could be underneath, and you might never know that. The prevalence of these premalignant lesions, and probably no surprise that we find a lot in the body and the lesser curvature. and around the gastric angle. One of the predominant sites also for gastric cancer, so of course also for the precursor lesions. So have a good look, because this is also part of the blind area. So easy to miss if we don't look in retroflex. And then if we find atrophic gastritis or intestinal metaplasia, we're probably all aware of the OLGA classification or OLGIM classification. It's more or less interchangeable, and it tells us something about the risk of developing gastric cancer when there is atrophic gastritis or intestinal metaplasia. And if you go from left top to right bottom, the risk increases. There is either no atrophy to severe atrophy, and we know that if it's only in the antrum, probably the risk is very low and there's no need for surveillance. And if it's both in body and antrum, you get to a higher stage, and probably these patients are at risk of developing early cancer. Now, if we combine white light endoscopy, we take biopsies, but we combine this with narrowband imaging, our yield improves. This is an older study where we already saw that. We see more intestinal metaplasia. You see this light blue crest. You can even recognize dysplastic areas. And this has been further studied by our Portuguese friends, who did this study in real-time use of narrowband imaging during endoscopy. And they compared that to the intestinal metaplasia from biopsies, so histology compared to real-time endoscopy. And here you see a few nice pictures of normal stomach, normal mucosa in white light and narrowband imaging. You see the intestinal metaplasia in the bottom, and you even see a dysplastic area. And they compared this endoscopic grading of intestinal metaplasia to the histology, and actually there's a good diagnostic accuracy of 94%. So for a trained endoscopist, can easily distinguish intestinal metaplasia just as good as a biopsy. So that's an important finding. I think we're all aware of this, the MAPS guidelines. It tells us what to do with intestinal metaplasia or atrophic gastritis. And basically, well, the left side of the table is probably not very interesting for us right now, but it's, to sum it up, it is always eradication of H. pylori whenever there's atrophic gastritis or intestinal metaplasia. And when we find it both in the antrum and in the body, there's also a reason for endoscopic follow-up every 3 years. And by the time we find a dysplasia, this interval is shorter. So when we find no visible lesion, but we find dysplasia, there is follow-up in once a year. And if we do find an endoscopic visible lesion, of course, we need to resect that and stage, and then follow up, decide on the histology of the resection specimen. That's on the right side here. So, and there's also evidence if we do that, this improves this improves survival. So this strategy works, and I showed you in the beginning that having gastric cancer is very, very fatal, and doing good surveillance and finding lesions and treating them means improved survival for patients. Now, so finally we found a lesion. I'll show you a picture of a lot of lesions, and some are very subtle and some are very overt, and some are endoscopically resectable and some of them are not. And I hope that we can all see that the ones on the left are the ones I would attempt an endoscopic resection, but the ones on the right, where you see the converging folds, or clubbing, or the deep ulcers, these are the ones that are beyond endoscopic cure. So we need to send them to surgery. Now in the next, I'll show you a lesion that I found, and I think peristaltic wave is always a good sign to tell us, are we dealing with a T1 or a T2 cancer? Because basically a T1 cancer is one that we can resect endoscopically, and the T2 we cannot, even though the T1 could still be outside criteria, but at least we know that there's no deeper invasion than that we can cut. So normally when we would be in a classroom with all the people, I would now ask everybody to raise their fingers. I'm not sure if we can. Who thinks that this is a T2 lesion? Is it something that we can try? I'm not sure if I can see people. Everybody is online on video.
But they can type eventually.
Maybe that's better. So
should be also possible to raise the hand digitally.
Say again.
It looks very depressed. It feels like T2.
Okay. Anybody else has a different opinion? So who thinks this is a T1 lesion, or nobody?
I think it could be T1.
Okay, and can you tell me why?
Yeah, because there is seems to be an ulcer, but it's not too big, and it seems to move with the mucosa. So maybe you could try just to do a histological diagnosis or maybe curative.
I agree. So I think what you should appreciate in this video, you can clearly see the peristaltic wave, and that is the muscularis propria that you see moving. So I think in this video, the lesion is not attached to the muscle layer, because the muscle freely moves underneath, and this is like the floating duck in the water. It moves over the peristaltic wave. So I think the lesion is not attached to the muscle layer. If that would be the case, then probably the peristaltic wave would move around it. So in my experience, this is a lesion that is a T1. And I can tell you for sure, because this is a lesion that I resected. And it was actually an SM1 early cancer. Yes, so look at this. Normally, invasion in the muscle layer, a lesion, the peristaltic wave would move around it. So this is additional information on a macroscopic view, just real time. You see this moving like this, you probably have a T1 lesion. Okay? So, the next question would be, are we going to resect this with EMR or ESD? We're all in an ESD workshop and all eager to do ESD, so of course we would all vote for ESD. But is there any evidence to back that up? Well, I think the indications for ESD stand when the unblock resection matters. Lesions are either too large for unblock EMR, because clearly a piecemeal resection of a lesion like that we would try to avoid at all times. Pathology would have a hard time assessing the radicality of the lesion. So, and there are issues on local recurrence. I'll show you some data. So when all of that is there, so the incompleteness of the resection or the uncertainty about the completeness will influence patient management, because it might very well be that a piecemeal resection of a lesion like that, we might end up sending the patient for surgery because we just don't know if we did a complete resection. So I would always do an ESD for gastric early cancer. Now, why do ESD? Well, if you want to have an en bloc resection, these studies clearly favor ESD. They all do. So for en bloc resection, you should do ESD and not EMR. EMR can sometimes be disappointing. I know there are lesions that we can resect with EMR, probably a few of the lesions that are less than 1 centimeter in size, but it can be very disappointing if you don't have a good lift, you try to, and your snare snugs to the lateral sides of the lesion, and you still have an R1 on the lateral side, or maybe even too shallow on the vertical side. So go for a proper ESD, where you can manage also the lateral margins with ease. This is some data to back that up. This is recurrence in piecemeal in EMR lesions versus ESD lesions. And you see a good ESD, you have no recurrence. And even with good EMRs, you still have recurrence, and up to 20% for lesions between 1 and 2 centimeters. So we shouldn't go there. Another thing, I often get referrals. There are lesions or patients or colleagues who want to discuss. They have a lesion with low-grade dysplasia. Well, low-grade, we can do endoscopic resection, just EMR for that, can we? Well, please bear in mind that after resection, there is an upgrade in the histology to high-grade or cancer of about 20% when low-grade dysplasia was found on a biopsy. So don't trust a biopsy all that much. If you see a visible lesion, and if you are a skilled endoscopist, I would certainly go for ESD there. And this figure is even higher for larger lesions. Yes? So if we look at R0 resection, and that's in the end, certainly for the cancers, what really matters, this clearly favors ESD. So no EMR for early cancers, but ESD. And also for recurrence rates. So I think this is also in favor of ESD. I think on all fronts, there's good evidence that ESD is superior to EMR. Of course, maybe that's not a fair comparison. We should compare ESD to surgery, because surgery was the gold standard for early gastric cancer. Well, if we look at this study, ESD versus gastrectomy for the early cancer cases, I think the numbers are equal, but of course, there is less procedure time for ESD, there's less blood loss, there's less hospital stay, and less complications. The other survival, etc., the figures are more or less comparable. You might say that survival is better after ESD, but I'm not sure why that is. But sure, on the other, like complications and hospital stay, etc., clearly favors ESD. So I think ESD for early cancer also wins compared to surgery. And that's of course why the ESG guideline favors ESD as the first line treatment for gastric early gastric lesions. Okay, so maybe part of this was already discussed by Michael Hefner in a previous presentation last week, but repetition makes people remember, so I think we can go briefly through this. Be prepared for your procedure. Think about which type of endoscope and working channel you're going to use. Do you want a scope with a large bore channel, or you want to go for the most flexible type? You want to go for the therapeutic gastroscope or a diagnostic gastroscope? Usually I go for the most flexible endoscopes. I choose the diagnostic gastroscope. I will scope with a transparent cap. use CO2 insufflation, and of course have my high frequency generator available. And basically on the shelf, everything you need for complication management. I can just sum it up like that. And specific, well, chromoendoscopy, if you're in the stomach, usually I think I manage with white light and narrowband imaging. And there are some subtle lesions that are hard to delineate that you can spray with indigo carmine for better delineation. And of course, then you need your ESD knives ready at hand. I think one of the important things is your submucosal injection fluid, don't make this too blue. I like blue, blue is my favorite color, but if it's dark blue, it will be hard to distinguish the blood vessels. And you will see bleeding as oozing red blood, but you don't see the vessel, so you don't know where to treat. Make it very light blue. It's the only purpose here is to distinguish a muscle layer which doesn't stain and stays white from submucosa which stains blue, and the backside of the mucosa, if you are under the lesion, also stays white and doesn't stain. So that's the only reason you need only a few drops of blue in your solution. And then where do you cut? So this picture, you see this is the submucosa with all the blood vessels. And on the bottom, black is the muscle layer, and on top, black is the mucosa. So this is the submucosal layer with the blood vessels branching off, and you can divide it somewhere in SM1, 2, and 3 layer. And basically, what I would like to show you here, if you stay very superficial, you might feel safe because you're far away from the muscle layer, but you are close to the mucosa, so close to your lesion. You find all these small vessels. You have numerous tiny bleedings. You cannot really see them really well. And I would go for the lower layer, somewhere between SM2 and 3. There you probably find the root of the vessel. And when you treat it, you're done with the bleeding. You stay close to the muscle layer. That means if you stay close and you can see the muscle layer, you can prevent cutting the muscle layer, hopefully. And another of maybe the most important reason why are we doing this procedure? We're doing this to have a radical endoscopic resection. So it makes sense to stay as far away from the lesion on the vertical part as we can for our best chance of having a curative resection. Yes, so stay in the lower part of the submucosal layer. Now, there's a different approach for every lesion in every organ, and also maybe for different types of knives. So I'll just focus on the stomach. Usually in the stomach, it is hard to distinguish lesion from normal mucosa. It all looks a bit adenomatous, especially if you start cutting and lifting, it doesn't become clearer, unlike in the colon and some esophageal cases. So in the stomach, I would say mark around and always make a full circumferential incision. Always, not always, but in general, always. I like to use the most flexible endoscope, which usually has a smaller working channel, but basically all working channels are big enough to fit a standard ESD knife and also your coagulation grasper and clips. So you have more angulation control, then use a transparent cap, and whenever you can, use gravity in your favor. The ESD in the stomach, what is the difficulty there? So I already told you, difficult to delineate. Use your high definition endoscope, use chromoendoscopy, narrowband imaging, or indigo carmine if necessary. Then make sure you place very clear markers, because the faint markers halfway the procedure, you don't know, was this a marker or was it something else? You get confused. So place very clear markers. There are a lot of difficult positions in the stomach. If you inflate a lot of air, you make paradoxic movements. Sometimes you are during the procedure, you find yourself in retroflex. Sometimes that's just the position that you have to be in. And sometimes it's easier if you take out a lot of air and you find yourself in an easier position, like how you started. And another difficulty, especially if you're in the body of the stomach, you'll see a lot of blood vessels in the submucosal space. And you'll have a good time treating a lot of bleedings there. So this is basically my standard strategy for ESD in the stomach. This is a lesion which I marked already, and you see the proximal end at the bottom and the distal end, so towards the pylorus at the top of the screen. And what I do with an I-type knife is usually I circle around from one side and I choose the most difficult side, the lower part of gravity, because whenever something starts bleeding, that's where the blood and fluid piles up. Then I take the other side and I leave a small tissue bridge here. That's only in the beginning, and it makes it easier to finish the backside of the lesion, because during a circumferential incision, sometimes the lesion lifts up very high and you cannot see the backside of the lesion anymore. The tissue bridge prevents the lesion from flipping up completely. It pulls it down so you have a better view. So by the time you almost did a 360, you cut this tissue bridge, and then basically you dissect from 6 to 12 o'clock, so in like this. Yes, so standard forward approach, the easiest. Of course, in different positions, there are different approaches, and gravity can make things different, but this is my standard takeoff for most lesions. So visualize and mark your lesions. This is the same lesion you saw in the video earlier. So I'm marking around the lesion, usually 2 to 5 millimeters away from the lesion. And I often get the question, how far apart should the markings be? Well, the best answer is that at all times when you have a cap on the endoscope and you are close up to the mucosa, you want to be able to see 2 markers at all time, so you know where to go. If you only see 1 marker, you have no idea. If you can see 2 markers, you know in which direction you have to cut. And you can see that in the next video, hopefully. So here I see 2 markers and I inject and I start cutting around. I see already my next marker coming, so I know exactly where to go. Part in retroflex, so paradoxic movements, making it difficult, injecting and cutting. And from this marker, I try to see the next one, and I see that I have to cut more laterally and slowly can circle around this lesion. See, at all times I can see 2 markers. I can inject and continue to cut. If you do it like that, in a close-up fashion, without any overview, you can just circle around your lesion in one go. Okay. And once you've done the circumferential incision, you do the submucosal dissection, and this is already at the end. There's still a blood vessel here. Blood vessels like this, you can treat with a grasper, but you can also treat it with a knife. Inject a little bit around it for safety cushion, and then with coagulation, cut the vessel and be done with it. Okay. Well, I think your pathologist will be very happy if you pin the specimen down. Usually when you just throw it in a jar in formaldehyde, it will curl at the edges and your pathologist will find cancer at the surface, but also at the bottom, so they don't know if it's a radical resection or not. So pin it down for orientation will help your pathologist and increase your R0 resection rate. Yes, like that. One of the last pictures here. This is one of an early case. In the antrum, you see the pilorus is partly obscured by the lesion. In this case, a different approach. We mark around, and then we start cutting. Basically, we cut around the pilorus, and the elasticity of the tissue makes the lesion pulls itself towards the antrum, and then making it a more standard ESD again. And when you do it the other way around, you start at the antral side, the lesion will be pulled into the pilorus, and you will have a very hard time resecting the rest. So there's always a strategy for every lesion, and you have to think upfront how your approach will be. So make a plan for every lesion. So a few take-home messages. I think it's disappointing that despite 30 years of research and therapy, still gastric cancer in the advanced stages has very poor survival. So here, to prevent is really better than to cure, and probably for gastric cancer even more true than for a lot of other precursor lesions. But of course, we have to recognize them. And I told you that we have about 1,500 cases of gastric cancer in the Netherlands, and I can tell you for sure that we're not doing even close the number of ESDs for early gastric cancer. So we still need to recognize and find these precursor lesions. If we do, I think endoscopic treatment is very feasible and is even the preferred treatment for these early cases, and we can really cure the patients. Okay, thank you very much for your attention. Any questions?